Good afternoon, everybody. Is it audible? Is it audible? Hello?
No.
Hello? Check. check. Hello? Hello? Ah, yes. Okay. So, good afternoon. I welcome our director, sir.
Yeah, as much as a part of
Sure. So I welcome everyone, and thanks to everybody for sparing time on a Saturday afternoon to be here for the day 2 of our annual Research Day celebrations. So today we are having the MDMS, the junior residence paper presentations. Oral presentations will be held in this hall. So I'm very happy to introduce our chairpersons for today, Dr. Basit, who is a junior resident in the Department of Preventive and Social Medicine, and Dr. Ahalya, who is a junior resident in the Department of Nuclear Medicine. So they will be conducting the proceedings from here on. I hand over the session to the chairpersons.
Thank you. So thank you, Dr. Vikas Menon. So all of us here are good players and we know the rules, but some repetition is in order. So first I'm going to give you the instructions for the presenters. So presenters, speakers, please listen carefully. Each of you gets 10 minutes. You get 8 minutes for presentation, 2 minutes for discussion. So if you finish your presentation in less than 8 minutes, there will be more time for discussion. But we will hit the buzzer once at 7 minutes, second time at 8 minutes, and at the 10th minute, we'll long the buzzer. So am I clear to all the speakers?
May I have your permission? We need a volunteer from among the residents. Yeah. There is somebody. So when the resident asks questions, they get a comment. When the faculty asks questions, they do. Okay. Unequal.
Yeah, so we'll ring the buzzer once at 7 minutes, once at 8 minutes, and a long press at 10 minutes. So at 10 minutes, you'll have to step off the stage and let the next speaker begin. And so yeah, only the presenting author can respond to questions. And your co-authors and your senior faculty members are not allowed to doing any of these things can entail disqualification. So yeah, nobody is allowed to answer from the authors. And if you exceed time or if your co-author or senior author answers or chips in, then yeah, you could be disqualified. So do you have any questions? Any questions from the speakers? You can also ask each other questions once your presentation is done for your presentation. So moving on.
Some ground rules for the audience. First one, please keep your phones in silent mode and please ask questions, but only after the speaker completes speaking. Raise your hand, then we'll bring the mic over. And I know we are a bit pressed for time, but and close in the short time, but we'll make sure that there's no dull moment in the session. So for our first presentation, we have Dr. Ankit Kumar. Oral and maxillofacial surgery. In between the huge patient load in our clinical setup and the media overload, nowadays we are very able to keep up with the patient education, and often it doesn't receive the attention that it does. So Dr. Ankit's research concerns with this complex issue, that is preoperative patient education. So Dr. Ankit, the floor is yours.
Okay.
Good afternoon. So, an impacted tooth is a tooth which fails to grow in the oral cavity in its correct position beyond its chronological age. And the impacted teeth which are most commonly impacted are mandibular third molars. The teeth often presents with various pathological conditions such as chronic food lodgement causing caries, pericoronitis, and cysts of the mandible. These teeth associated with such pathologies need to be removed surgically to prevent any further damage to the adjacent teeth and the bone. Patients undergoing this surgery are often very anxious, and failure to identify such patients can cause difficulty to both the patient and the surgeon during the perioperative period. One way to minimize this anxiety would be to provide a pre-operative patient education, that is, a PPE, in which the surgeon would explain the patient verbally the proposed surgery, its alternatives, risks, and benefits. However, the verbal mode of modality has certain disadvantages as well. A busy surgeon may rush through PPE or may use complex medical terminologies. A pressurized patient may feel pressure to accept the proposed procedure. A common complaint of many patients in malpractice claim is that surgeon did not explain the procedure properly to me. So it's essential for a surgeon to make sure that the patient has fully understood the procedure and is making an informed decision. Alternatives such as audiovisual aids have been employed in few studies. However, there is no clear consensus on whether the audiovisual PPE is better than the verbal PPE. So the aim of this study was to compare verbal and audiovisual PPE on the perioperative anxiety and understanding of the PPE among the patients undergoing third molar surgery. This randomized double-blinded trial included healthy adult patients who reported for surgical removal of impacted mandibular molars. Any patient who had already undergone this surgery was excluded. A total of 76 patients were recruited and their demographic data was recorded. On the day of recruitment, the basic anxiety was assessed using STI-T questionnaire, which is a set of 20 questions with a scoring range of 20 to 80. A score above 37 was considered to be moderate or high anxiety. Participants were then randomized into two groups, that is, the verbal PPE group and the audiovisual PPE group, through computer-generated random numbers. The audiovisual PPE group was received information through a 3-minute animated video with a voiceover. The sequence and depth of the information was identical for the both groups, after which the surgical appointment was scheduled within 3 to 7 days from the time of PPE. On the day of surgery, knowledge retention was assessed using 10-item single response questionnaire, which was based on the information provided in the PPE. Preoperative anxiety was assessed using self-reported visual analog scale and non-invasive hemodynamic parameters at 3 time points, that is, before and after local anesthesia, and once the surgery was completed. Both the surgeon and the assessor were blinded. On the day of suture removal, both the VAS scoring and the knowledge retention questionnaires were repeated. Student t-test and chi-square test were used to analyze the data. 6 patients were dropped out and were excluded from the final analysis. Baseline characteristics were found to be similar, and mean age in both groups were comparable, with the STI-T scores being the moderate anxiety. We found there was a similar trend in VAS in both the groups, with an increase from baseline after local anesthesia. This is not an unexpected finding, since the administration of local anesthesia is the most painful part of the surgery. Once the local anesthesia started acting, we found the values were decreased. Other non-invasive hemodynamic parameters also found at the same trend, and they were not significant. Statistically, they were not significant. On basis of knowledge retention, we found the mean scores in verbal and audiovisual was 7.9 and 7.7 respectively, and it was also not statistically significant. On the day of suture removal, the mean score was marginally increased to 8.4 and 7.9 respectively, and these scores were also not significant. Interestingly, we found that there was a statistically significant difference in the mean scores in the verbal group during the 2 time periods. So what about the studies which used audiovisual aids to deliver PPE? Contrary to our expectations, the videos which were used were found to increase perioperative anxiety. It was interesting to see they used recording of an impacted mandibular third molar surgery on an actual patient, which was found to be counterproductive in minimizing the anxiety. Images of bleeding from gingival incisions, cutting of bone, and placement of sutures might prove being normal or routine to the surgeon, whereas these images to the patients were found to be maybe the first exposure. And these guidelines, we can say, are similar to the media houses since they are restricted to not transmit the images of dead bodies during the time of any terror attack or during disasters, as such visuals can be disturbing to many viewers. Instead, some surgeons have used animated videos with subtitles or slideshow presentations for PPE. They observed that there was decrease in preoperative anxiety. However, our study, we did not found any significant decrease in perioperative anxiety, although we used a 3-minute animated video. Although patients might blame surgeon for not providing adequate information, forgetfulness on the part of patient cannot be discounted. Many surgeons have recommended that a review of information just before surgery will be required. However, critical examination was proved that they had a time gap of 18 to 37 from the time of PPE to the surgery. So why is this time gap very important? A German psychologist, Ibn Gus, who discovered the forgetting curve, noted that there was an exponential loss in the information that one has learned if there is no further attempt to retain it, by almost 90% of information forgotten by the day 6. We have tried to avoid this potential confounder by making sure our patient was scheduled within 3 to 7 days. Randomization, double-blinded trial with minimal time period between PPE and the surgery are some of its potential strengths. As per our knowledge, there are no similar studies which has been published on Indian population. We cannot guarantee if patients have sought any additional information, which is our potential weakness. So, in conclusion, although statistically insignificant, we found that there was lesser self-reported anxiety scores in audiovisual group, and the retention of PPE was found to be greater in verbal group. The OMF surgeon may use both the modalities so that the patient's anxiety can be reduced perioperatively. Thank you for a patient hearing. Jai Hind.
Thank you, Dr. Ankit. That was an intriguing and relevant thought for discussion. Now the session is open.
Thank you.
How do you standardize the doctors?
The information you are telling, like the information which has been given to patient, how we have standardized in verbal group and audiovisual group. Is it the right? Yeah.
The video is too much.
Yeah, almost roughly around 2 minutes 35 seconds. Actually, yeah, I'll let you know what actually we did. There is specified instructions which has to be given to all patients in verbal modality. They are specified. So what we have done, we have validated that information in both Tamil and English by reverse translation by a senior OMFS faculty outside, which was not related to our department. And those voiceovers, that same information which were there in verbal, we have kept in video. So it is synchronized with that.
The issue which you told is the doctors are not spending much time. That's why we want alternative like audio.
Yeah, we made sure that the same time period was used to deliver the verbal information. We didn't try to exceed it to 10 minutes and showing only 2.5 minutes. That we make sure we do. That was done by 2 of our faculties. So we make sure it was standardized for all patients.
Like Indian study, that double blinding.
Yes, sir. Actually, the 3 components will be there in a study: patient, the surgeon, and the assessor. So patient cannot be blinded since he knows about what intervention was given to him. Either it was a video or a verbal. But surgeon and the assessor who was recording the data, both were not aware in which the patient went. So both people were blinded.
No suggestion.
Sir.
Because talking to a patient, doctor face to face is really very easy.
Yes, sir, definitely,
So,
sir.
really, this suggestion, so if you want to do it again, it may be better to do a doctor explanation versus doctor explanation with edit audio visual, rather than compare. Because one would think that that allows you opportunity to ask questions and get that.
So that we have done actually. It is not like we have just shown the video to them. We have given opportunity after video patient came for any clarifications if they had. That we have done, sir.
Thank you, Dr. Ankit.
Thank you so much.
What was the surgeon?
No, ma'am. If the one thing which I like to explain is surgeon blinding is very important in this, since the anxiety portion we are assessing. So suppose I am a surgeon who is doing a surgery on a patient, and I want my study to show that audiovisual is better. Definitely, I'll try to be more. I'll try to make patient more comfortable. Yeah. So during the procedure, the surgeon should not know. He should be blinded. So he should treat our all patients as equal. So that is that we made sure our surgeons don't ask. That we cannot do anything more than that now. Thank you.
Thank you, Dr. Ankit. Moving on to our next presentation. Physical side infections are one of the healthcare associated infections. A huge amount of our time and resources go into its treatment. Its prevention is an equally or more than equally an important aspect. Our next presenter is Dr. Dabalna Pal of General Surgery and her paper DSHS. So, Dr. Dabalna, you may please proceed.
Good afternoon to one and all present here. I'm Dr. Debolina Pal. The title of my study is Prophylactic Negative Pressure Wound Therapy, Reducing Surgical Site Infection in Closed Abdominal Incisions. Post-operative complications are a common occurrence in abdominal surgeries, which include surgical site infections, seroma, hematoma, and wound adhesions. The occurrence is around 5 to 15%, and it causes significant morbidity, including extended hospital stay, lower quality of life, higher healthcare expenses, and delay in adjuvant therapy in cancer patients. Several measures have been practiced to reduce the incidence of SSI, which includes conventional wound dressing to most advanced methods such as prophylactic negative pressure wound therapy, which we are dealing with in this study. So how does prophylactic negative wound pressure therapy help in closed surgical incisions? It acts by reducing fluid accumulation in avascular dead spaces. It increases blood flow in closed incision sites. It reduces shearing stress at the suture lines, and it increases the lymphatic drainage. So the primary objective of the study was to compare the effect of prophylactic NPWT and SSD on incidence of surgical site infection in closed abdominal incision. And the secondary objectives included to compare the duration of dressings required, number and type of wound complications other than SSI, and the length of hospital stay and the post-operative pain, and the need for readmission for 30 days after surgery, and to assess the risk factors for SSI. So this was a single center open label parallel arm study, superiority randomized controlled trial, which was done between November 2020 and June 2022. So all patients over 18 years of age undergoing elective surgery involving midline laparotomy under type 2 clean contaminated wound category were included, and patients who underwent laparotomy which wounds were not closed, laparoscopy assisted procedures, and patients who underwent second look laparotomy within the same admission were excluded from the study. Patients who developed allergic reactions and who did not tolerate NPWT were withdrawn from the study. Taking the expected rate of SSI in the control arm as 31% and in the intervention arm as 9.7% from a previous study done by Javed et al. And taking confidence interval of 95% and power of 80%, the sample size was calculated to be 128 with 64 on each arm. The sample size, taking consideration of the 10% dropout rate, sample size came to be 140 with 70 in each arm. Patients were randomized in 1:1 ratio, either into SSD or NPWT groups. Coming to the study procedure, there were two groups, experimental arm and the control arm. The experimental arm received PNPWT. So immediately after the surgical incision was closed, a sterile absorbent gauze or foam was used in the dressing, a Ryle's tube was connected, and a transparent adhesive drape was used to create an airtight space. And it was connected to a suction device which provided a pressure of 125 mmHg, negative pressure. and the control arm received a routine standard surgical dressing. NPWT was applied for a minimum of 3 days and a maximum of 10 days. And the length of hospitalization and the postoperative pain on day 3 and day 5 was measured using visual analog scale. And the patients had been explained about the signs and symptoms of SSI during the time of discharge and was inquired the same over phone on post-op day 30, and the information was recorded. The following data were collected from the patients: demographic data such as age, sex, BMI, clinical data, ASA, class, comorbidities, smoking status, neoadjuvant therapy, diagnosis, sugar, hemoglobin, and albumin, and postoperative details such as type of surgery, wound class, duration of surgery, amount of blood loss, and number of blood transfusions, and the postoperative details such as presence of SSI and other wound complications, duration and number of dressings, and the length of hospital stay. The signs and symptoms of SSI was interviewed, as I had told, on the post-op day 30 and was recorded, and readmission within 30th postoperative day, if occurred, were collected. So the continuous variables were summarized as mean and standard deviation, or median and interquartile range as per the distribution, and was analyzed using unpaired t-test. And the categorical variables were summarized as frequencies and percentages using chi-square or Fisher-Exact test to analyze. Logistic regression was used for detailed analysis of factors associated with SSI. A p-value of less than 0.05 was considered significant. Moving on to the results, 22 patients out of the 162 that were enrolled were excluded, and out of the 140, 70 were in the control group and 70 in the intervention group. Out of the 70 patients who received NPWT, one of them developed allergic reaction, so he was excluded, and the rest were followed up and analyzed. So this table shows the comparison of baseline characteristics such as age, BMI, gender, smoking status, neoadjuvant therapy, ASA class, hypertension, diabetes, and other comorbidities, which were comparable between both the groups. As we can see, the p-value is more than 0.05. And this shows the comparison of blood parameters. This shows the comparison of blood parameters and the intraoperative events, and these are also comparable between both the groups. So coming on to the primary objective, the incidence of SSI in patients who received standard surgical dressings was 28.5%. That is 20 out of 70 patients had developed SSI, whereas in the patients who received negative pressure wound therapy was 4 out of 69, which was 5.8%, with a p-value of 0.001. So there was a significant reduction in the incidence of SSI in patients who received PNPWT. And among the patients who had SSI in the SST group, 17 out of the 20 had superficial, whereas 3 out of the 20 had deep infections, whereas all the 4 patients in PNPWT group only had superficial SSI. And when we look at the other complications such as seroma and dehiscence, both the complications were comparatively lower in the PNPWT group as compared to this standard surgical dressing group, with a p-value of 0.016. This is the comparison of secondary outcomes between the study groups. So length of hospital stay, it shows a reduced length of trend towards reduced hospital stay in the patients with PNPWT dressing. But it doesn't show a significant value, as the p-value is 0.07. And the pain on post-op day 3 was found to be significant with a p-value of 0.02. Apart from that, the number of dressings were lesser in the group which received PNPWT as compared to SST. And the other outcomes, such as pain on post-op day 5, readmission within 1 month, and SSI after 1 month of surgery, were not significant. Coming to the conclusion, prophylactic use of negative pressure wound therapy in closed incisions following elective laparotomy can reduce the incidence of surgical site infection. The use of PNPWT was associated with a lower incidence of deep SSI, seroma, wound dehiscence, decreased hospital stays, and a fewer changing of dressings during the hospitalization. More adequately powered studies are required to clarify the effects of PNPWT. Further studies are needed to explore the effects of PNPWT on hospital stay, cost analysis, and types of SSI. Thank you.
It was an insightful presentation. Now the session is open for you. So in your study, we have seen that surgical site infection in both the group. One group was like 29%, and other group it was like 6%.
Yes.
But when we look at the hospital stay, it was like 10.5 and 9. The difference was like too little. Would you like to explain it?
Yeah. So as we see in the standard surgical dressing group, it's mostly 17 people had only superficial SSI, which doesn't need too much intervention. So that doesn't change the hospital stay that much. Yes, sir. Yes.
Is it the ideal way of adjudicating on experience of treatment? Considering the primary outcome?
Yes, sir. Like ideally, it would be better if we could see the patient at SS, and there are various criteria. Like we could either see microbiologically, or we can if there is a frank pus discharge, or if the surgeon tells that this is a surgical site infection, it would be considered as so. And like it was not that all patients were told to have surgical site infection only based on telephonic interviews. There were a few patients during the hospital stay, they had developed surgical site infections. So the patients in whom we couldn't see in person, all those were through the telephonic interview, and those data were included.
Thank you, Dr. Dabalina.
Thank you.
Moving on. Comments, romantic thinking into medical history in 1929. The nemesis of this technique
Yes. Yes.
The nemesis of this technique is thrombosis, and it continues to be challenged in this stage. Our next presentation promises to enlighten us about this very issue. So, Dr. Aditya Narayan, Department of Pediatrics, please take.
Good afternoon, everyone. Can you hear me? Okay. So I'd like your attention for the next 8 minutes. I'll be telling you all about a very important complication of a common procedure that we're doing day to day in our clinical practice. So my study title is Venous Thromboembolism in Pediatric Patients with a Central Venous Catheter, and it's a prospective observational study. So what we have to know first before going into the study is that venous thromboembolism is the second most common cause of morbidity in hospitalized patients, the first being infections. So, and the incidence of these thrombosis has increased tenfold in the last 2 decades. Now, the reason for this increase in our thrombosis in the last 2 decades is one, our increase in ICU care practices. Two, are the more complexity of surgeries we're doing and the longer duration of hospital stay. And the last and the most important is the CVC insertion, which is the single most common risk factor for the development of VTE. So prospectively studying the incidence and risk factors of this problem will help us plan prophylaxis as well as treatment strategies. So the objective of our study was to study the incidence of thromboembolism in children with central venous catheters. And our other objectives were to also study the risk factors as well as the incidence of non-thrombotic complications like CLABSI. So we had done a prospective observational study on pediatric patients who were admitted to the Department of Pediatrics and the Department of Medical Oncology having a central venous catheter inserted for their treatment. As you can see, after we had included patients from the Department of Pediatrics. Here we had mainly included patients in the pediatric ICU who have a critical illness. And from the Department of Medical Oncology, we had included patients with us who are receiving chemotherapy via central venous catheter. We had followed up these cases till either the development of symptoms or till the catheter was removed, either after its completion of its course or for any other reason. And we had screened for venous thromboembolism using duplex ultrasonography, which is both compression as well as Doppler ultrasonography. And this was done within 48 hours of removal of the catheters. We excluded the cases where we could not perform this. So we had, the incidence of all these thromboses studied in the past varies from 15 to 35%. We assumed an incidence of 30% and calculated a sample size of 104. So in our study, we enrolled 188 patients, but out of the 188, 84 we could not perform a Doppler due to either death or for any other reason. So at the end, we had 104 children who had followed up to the end of our study, who had a median age of 3 years and whose 75% were males. And for these 104 children, we were able to perform a duplex ultrasound. Now, finally, what we found that 45 out of these 104 children, which accounts for 43% of the children, developed a thrombosis. But the incidence of symptomatic thrombosis, that is, which of these thrombosis had symptoms, were 1/4 of the cases, which included a total of 11.5%, or 12 out of these 104 cases. So what is important in our study is that our cohort included a wide variety of patients. So we had patients who were post-surgery, patients who were critically ill, patients who received renal replacement therapy with a HD catheter, and patients with chemotherapy. Now, what is important is all previous studies done to determine this incidence of thrombus have actually focused on specific cohorts, either critically ill children or children just receiving chemotherapy, or just surgical status. So in our cohort, we included all children, so we were able to get a more true incidence of the problem. So we compared the children with a thrombus and without a thrombus. So now we found we compared many factors like age, sex, surgical status, presence of malignancy. But what we found significance in our study, I've highlighted here. So what we found significance was, one, the CVC duration. The number of days the catheter was in situ was associated with the development of thrombosis, with a mean catheter days of 11 days for the thrombosis group and 8 days for the group without thrombosis. The other thing we found, that method of insertion, when catheters were inserted using ultrasound guidance, actually what we found that catheters which were inserted with ultrasound guidance had a higher risk of venous thromboembolism compared to manually inserted catheters. And last, what we found that the relationship between catheter malfunction as well as development of thrombus was significant. Even after doing a multivariate analysis, we found that CVC duration is a significant risk factor for the development of VTE with an odds ratio of 1.06. We also compared our cases of symptomatic thrombus. Those are the 12 people who had symptoms versus people with asymptomatic thrombosis. This is the 33 cases which didn't have symptoms of VTE. What we found that the patients who had a catheter inserted for drugs had a higher risk of developing symptomatic thrombus compared to patients who had a catheter inserted for hemodialysis. We also found out that short catheters had a higher risk of symptomatic VTE, as well as catheter malfunction was seen in all cases. That is 100% of the cases with symptomatic VTE. So final points which I'd like to highlight in my study are, one, the incidence of development of thrombus was 43%. So nearly half the catheters that we are inserting in our clinical practice actually develop thrombus. But and the incidence of CLABSI, what we found in our study, was 15.4%. But out of all these thrombuses that we're finding out, only 1/4 of them are clinically relevant or symptomatic. So which comes to around 11.5%. We found that CVC duration, which is the number of days the catheter is in situ, is a significant factor for the development of VTE. And we also found out that shorter catheters had a higher risk of getting a symptomatic thrombus. Now, the reason for this has been postulated by us and by one previous study. So what we suspect is that when there's a close proximity to the tip of the thrombus to the site of insertion, there is more amount of venous stasis causing more amount of thrombus formation. And last, what we found out is that catheters which were used for drugs had a higher risk of symptomatic VTE compared to HD sheaths. So the probable reason for this is that all the catheters which were used for dialysis, either intermittent or continuous renal replacement therapy, used the heparin locking system. So this probably contributed to the lesser incidence of symptomatic VTE in this group. So as you know, this study is just an observation study, and all these risk factors were studied in a non-blinded manner. So the further scope for this would be to study all of these risk factors in a randomized manner. Also, we'd like to further study the benefit of heparin locking system to prevent these thrombus. And last is, we don't know how many of these asymptomatic thrombus is actually significant and how many of these actually matter in a clinical setting. So we'd like to follow up these patients in the future to see whether they're developing any post-thrombotic syndromes. So these are my references, and thank you. I'll take questions.
So the study, we have seen the duration of catheter was one significant
Yeah.
factor. So I was just thinking like logically, is it really a modifiable factor? For example, if we are keeping a catheter, that could probably have one valid reason. So how much can we modify?
Exactly. So in a clinical, yeah, it definitely, we usually keep the catheter as long as it's required, and we usually cannot modify this. But with this information, we might be a little more vigilant and little more. We try to early and try to expedite our process of removing the catheter earlier.
So very interesting. But you had out of 188, 84 people.
Yes, sir.
They did not have the procedure to assess.
Yes, yes, sir.
Is it possible that those 84 were very different from the 10?
Yes, sir. So out of this 184 children, out of this 188, among the children we couldn't assess 84. Like 64 of them expired before we could perform the ultrasound because they were critically ill children.
The second question is, when you say ultrasound guidance was associated with a higher risk.
Yes, sir. Okay.
And also a shorter length.
Yeah.
Is it possible that both ultrasound guided procedure and a shorter length was associated with smaller size of the baby, and that was the risk factor?
Definitely, sir.
Rather than a smaller baby,
yes, sir,
is more likely to have an ultrasound guided procedure, and also it's more likely to have a shorter length between the.
So what is known right now in literature is that ultrasound guidance is definitely associated with lesser number of pricks, and this lesser number of pricks has been correlated with the development of this thrombus. So what we expect is actually ultrasound guidance to have lesser risk of thrombus. But in our study, we found that there was more risk of thrombus in ultrasound guidance. So the reason for this is actually 2 or 3 things. One is ultrasound guidance was used only when, it was when the catheter was anticipated to be difficult, either smaller child or when a difficult anatomy was accepted. So this is a significant confounding factor. As well as usually when we inserted catheters, we didn't measure the catheter vein ratio. We actually have to assess whether the catheter is a good enough size for the vein before inserting, which we actually don't follow in our clinical practice. So if we do this, maybe we'll be able to determine the true relationship between this ultrasound guidance and development of thrombus. Yeah. Yes. Yes, sir.
Second one is just babies typically might be on an anticoagulation, especially night. Can you see any information regarding that?
Okay. Yes, actually, majority of we haven't actually collected the data on anticoagulation, and that is significantly will confirm the results. But what we do know is that this heparin locking system was definitely not used in the ICU. And as per routine pediatric protocols and practice, no pediatric ICU child receives thromboprophylaxis. Thromboprophylaxis we strictly don't follow. The only small group which actually received thromboprophylaxis in our study is just the children who underwent cardiac surgery, like cardiopulmonary bypass. So this might be just a small group which actually received the prophylaxis and might have confounded the result. But our cardiac surgery patients were just 14 out of the 104 patients. So these 14 would have confounded the results that we expect.
Okay, let me level things up a little. Do you think the technician or the physician is inserted?
Yes, sir. So I've actually assessed for experience of the catheter. If you can see here, actually one of the things is experience of a person inserting the catheter, whether he's inserted 0 to 5 catheters in the past 5 to 10 in the past, 10 to 30 or more than 30. So as you can see, most of the catheters were inserted by someone with a better experience, but we could not find any significant relationship with that. Yeah, so experience correlates with, skill, we hope to expect.
Thank you, Dr. Aditya.
So now we'll continue if you ask questions. I just said I want to live. No, you are okay. I will ask questions, but I'm asking you asking questions you have not asked. Please ask. And for those of you who came in late, for those residents who ask questions, there is a chocolate.
There's no chocolate from me, but see, that will make it. I'm from director, so first ask. No, like most of us are like, medicals are always the stereotype. Stereotype is very good. So let's change that stereotype. And without cross-examining, without any implication, how do you ask?
Where are the chocolate?
But I don't know. I'm going to see chocolate. So I have a question. If you have a question, don't think, please.
Not for the faculty. Not for the faculty. Okay.
So we all have to become serious again. Our next topic is not fun that So John F. Kennedy once said that children is postages to fate. So our next presentation, it's a reminder of this very good fact that our childhood affects everything around us. It also has its implications in healthcare. So Dr. Betty Raghavan, Department of Community Medicine, I welcome you to speak about your presentation.
Good afternoon. Title of my study is Prevalence of Adverse Childhood Experience and its Association with Perceived Stress and Decision-Making Style, Community-Based Mixed Method Study. These are by co-authors. So, introduction. Global prevalence of adverse childhood experience, that is explained by WHO as any traumatic event experienced by a child before the age of 18 years, was 13% globally, and in India, study conducted in Kerala showed it as 57%. Some may overcome the effect of ACE, but for others, it may be a haunting experience. So adolescent and youth were more prone to stress, according to the previous studies. And also, ACEs may alter the stress perception and decision-making styles, but no studies were conducted in the Indian setting. So this is the rationale for our study. Objective: among the youth aged 19 to 24 years residing in Puducherry, to determine the prevalence of adverse childhood experience, to determine the association of adverse childhood experience with perceived stress and decision-making style, and to explore ACE in the cultural context. Study design. This is a community-based sequential explanatory mixed method study where quantitative part is followed by qualitative part. So in my study, quantitative part is the major chunk and a qualitative component explains the quantitative part. Then study participant, this youth aged 19 to 24 years residing in Puducherry. We selected this age group immediately after 18 because to reduce the recall limitation in recall, and our exclusion criteria was those with those participants who are differently able. So because this is a self-administered questionnaire, and study period was April 2022 to December 2023, and sample size was for quantitative. It's calculated 268 based on the previous prevalence, which was 57%, and absolute precision 6%, and calculating 95% of confidence interval. And qualitative, it was eight participants. And for qualitative component, we choose participants who had adverse childhood experience, but they have less stress and rational decision-making style. And sampling technique, we used for quantitative simple random sampling, and qualitative used purposive sampling. And study instruments, a few words. That is for quantitative part, we used WHO ACE questionnaire. According to this questionnaire, this adverse childhood experience was divided into 13 domains, including physical neglect, physical abuse, emotional neglect, emotional abuse, sexual abuse, so on. So that is like if one of the domains is yes for them, then that will be marked as one. They have experienced one domain. If one person has experienced 4 or more domain, he will be considered as he is having adverse childhood experience, he or she. Then perceived stress scale, this assesses the stress amount of stress in the last 1 month. And general decision making style questionnaire, it has 5 subcomponents, and we usually in this study we focus on rational decision making style, and who had scored more than 20, we consider him to be rational. And for qualitative part, we chose a semi-structured interview guide. What is happening? So this is the procedure. This I have already explained. Socio-demographic characteristics of the participant. In our study, we had almost equal proportion of the males and females, and education background, that is 54% were graduate in our study, either pursuing graduation or completed graduation. Occupation, 37% were employed and 34% were unemployed in our study. And socioeconomic status, for around 41% belong to class 2 socioeconomic class, and dropout before the completion of 12th standard was 23% in our study. So moving on. This is our key result. Prevalence of adverse childhood experience according to my study is 57%. And in our study, we found these 4 domains more had high proportion, that is community violence, that one person has witnessed any person being beaten in the street in his lifetime before 18 years. Community violence, mother treated violently in the household, physical abuse and emotional abuse. These were the 4 important things came up in my study. And severe stress was found to be 14.4%. National decision-making style was 41.3%. So this is the qualitative component. And under the global theme of adverse childhood experience, we subdivided it. We had 2 sub-themes: adverse childhood experience explained in the WHO scale and not explored in the WHO scale. That is, under those which was already described in the WHO scale, we found that community violence, though it was high proportion, it was normal. And for physical abuse also, we found that though it was in high proportion, it was very normal to the participants. And those which were not explored well in our setting were insult by the teacher, unconcerned parents, which made them to see parents in the compromising position, gender dysphoria, which was not accepted by the community and the family, economic hardship, and negative judgmental remarks. And this is the, we also found that those with adverse childhood experience had 2.18 times higher chance of having perceived stress in the adulthood compared to those didn't have. This is following the multivariable analysis. And also we found that those with adverse childhood experience had 29% lesser chance of having rational decision-making style in the adulthood compared to those without adverse childhood experience. So moving on to the discussion part, we found that prevalence of adverse childhood experience according to our study was 57.3%, which is more or less similar with the study conducted in Kerala. And also association with perceived distress. It was already proven that neurobiological relationship exists between adverse childhood experience and the stress, because it was a corticosteroid mediated long-term pathway. So it will get activated throughout your life. Then also the much studies were not there based on the adverse childhood experience and rational decision-making style, but it also previous study has shown that adverse childhood experience will activate the instant rewarding decision. So it is more or less like they won't be having rational decision-making style, which need a logical and systematic thinking. So exploration of community violence, like seeing fights in street, didn't impact on our children much. And also like alcoholic problematic father, domestic violence lead to loss of interest in studies, and insult by the teacher, acceptance of gender dysphoria, financial hardship are some of the other ACE which has to be explored. And strength of my study is, it's a community-based study, which is representative of population. It also have a qualitative component. And limitation was limitation in recall. Conclusion: every one out of the study participants every one out of 2 study participants had ACE. Participant with ACE had higher level of stress and non-rational decision-making style. A few childhood traumas have resulted in long-term impact, and also some ACEs were culturally not significant. Recommendation: we need early recognition at primary healthcare level and at school, and parents should be trained to improve the child rearing practices. Thank you. These are my references.
Childhood even actually not age goes. So 15, 19 to 24 classes beyond that age also. Actually, recall issues come to the kind of abuse.
Yeah, it is true. So true. Like in the previous studies, we have seen that above, like there is no upper limit for the scale. You can apply the scale up to whatever age. But we wanted to limit the limitation in recall. That is why we stick on to this 90 to 24 years. And another thing was like this is the group where previous studies have found had high amount of stress according to previous study, and this is known as emerging adulthood. That is like we are progressing into new career, new relationships, new marriage. So this stage is very important for one's in a one's lifetime. That is why we choose this age group. Thank you.
For you being a child, like you are told childhood trauma, but what is that definition of that age?
For this scale to apply, it is less than 18 years. 18 years or less. In the tool, it is defined as 18 years or less. WHO questionnaire. It is defined. It is free version. Sir, in my study, we only approached adults. But if it was the child, if I were approaching a child, I should have gone and complained to the police station because it comes under POCSO. So I can report to the police station and I can report the welfare associations for the rescue of the child.
So, Dr. Vitti, this is a cross-sectional study. May I suggest that those who were more stressed now were more likely to think of childhood experiences as having been adverse. If I'm today more rational, less anxious, less stressed, my father shouted at me in childhood, my mom hit me, I still don't think of those as adverse events. And if I'm stressed now, it could be a reverse correlation.
Yeah, it can be.
Because, we are trying to say resulted in. I'm not sure whether that's true.
Yes, sir. It can be the other way around also. It is possible. It's like in the previous studies has found that it's better to follow the people and do a ambidextrous cohort study. That would be the better design. That decided, but practical physical.
It's more than nothing to do with the studies. It's a comment. When you are making your slides, you cannot give preference to one book, because you're not going to see it afterwards, right? It's not like a book where you can turn in your mind. You just mention whatever you put in the slide.
Thank you, sir. Thank you.
The last comment, we are relating the content, seeing that the categories what you show as the themes, whereas the question is actually put forward. Some of the things which is actually put in forward, you have made us we can really
Sir,
categories were the ones which actually show that you are asking.
Sir, that was that was detective coding we used, and here it is inductive coding.
Same thing. Some of the codes actually would have been the themes rather than you going back to the same question when you start.
Yes, sir.
Maybe.
Okay, sir. Thank you.
Thank you. More and more people today are embracing the idea of palliative care, and we as healthcare professionals are always trying to quantify this. Our next presentation is to do with that palliative care. I welcome Dr. Gupin Raj, Department of Community Medicine. The floor is all yours.
Okay. Good afternoon, everyone. My title of my study is Effect of Palliative Care Compared to Standard Care Alone on the Quality of Life of Patients Undergoing Cardiac Surgery at JIPMER, Puducherry. It is a stratified randomized control trial. These are my guides and co-guides. Why do we need to have palliative care for CTVS patients. We think that it is necessary for cancer patients alone, but WHO recommends that around 38% of the people, 38% of the cardiovascular diseases need palliative care services, and it is estimated that 6 million people in a year are in need of palliative care. So, and there is a research only with respect to the heart failure patients, which is done in cardiology department. There is a paucity of research in cardiac surgery patients. That's why I undergone this study. And my objective is to find the effect of palliative care integrated with standard care versus usual care for a period of 6 months on the quality of life and depressive symptoms of the patients undergoing cardiac surgery as compared to standard care alone at JIPMER Puducherry. My study design is a stratified randomized control trial. Here, I like to point a note that there are two groups. Here, first group is patients who are posted for cardiac surgery. That is like they will be posted for who will be posted for cardiac surgery. The second group is patients who are on follow-up care after cardiac surgery. So I'm studying both their quality of lives. And the study setting is both inpatient and outpatient wards of the Department of CTVS JIPMER. And the study participants is all adult population aged 18 to 65 years with palliative performance scale of more than 50. Here, the palliative performance scale has certain dimensions, like it has dimensions such as ambulations, activity, evidence of disease, self-care, dietary intake, and conscious level. And those who are scoring, those who have palliative performance scale of less than 50, it is less than 50 who will be posted. They are in need of palliative care, and they will be the one who will be taken for this particular study. And my exclusion criteria is that patients who are on wait for my group 1, it is patients who are on waiting list for cardiac surgery for more than 6 months. And for group 2, it is patients who are on follow-up period care for more than 1 year. Why I chose this exclusion criteria is that because those people who are at early treatment group, they will be more amenable for change rather than this particular population. And the data collection period is from 2 years. And the sampling technique which I used is consecutive sampling. And I used EpiCollect for data entry and Stata version 14 for analysis. And as it is a longitudinal study, I used a generalized estimating equation to estimate the change in quality of life scores from baseline to 6 months. And I performed intention to treat analysis with p-value of less than 0.05 was considered statistical significance. And for my group 1 of study participants, 15 patients were recruited, which 15 patients were recruited each in intervention arm and control arm. And for my group 2, those who are on follow-up care after cardiac surgery, 44 study participants were recruited. And based on the previous literature study done by Rogers et al., I calculated the sample sizes with mean difference of 16 points with standard deviation of 25. The estimated sample size was calculated to be 44 in each arm. And coming to the control arm, they receive the standard care, which is done by the CTVS team. The CTVS team will be doing the physical symptoms. They will be taking care of the physical symptoms and the counseling, which is done prior to the surgery. The intervention arm, it includes both standard care plus palliative care intervention. And palliative care intervention has multidimensional package. It has dimensions such as physical, psychological, social, emotional supports, which will be given to the patients by the principal investigator. And the duration of this intervention ranges from 30 to 45 minutes. It covers like many things, counseling sessions such as alleviation of fear and alleviation of loss of role in support, loss of role in the society. Those things will be health education, health counseling will be given to the study participants. And I'll be presenting the results of the group 1 participants first. These group 1 participants is those patients who are posted for cardiac surgery. And this is a consort flow diagram. 65 patients were assessed for eligibility, out of which 30 were eligible, and they were found to they were randomized into 15 each in intervention and control arm, and they were followed up over a different period of time points. I have highlighted that period of time points over there. They were followed up at different time points, like prior to surgery, 7th to 10th day after surgery, 1st, 3rd, and 6th month from the date of discharge. And out of which two participants, they died in both the intervention and the control arm. And but as I already told that I will be performing intention to treat analysis. So 15 participants in each arm were included for analysis. And the baseline characteristics of my study participants were comparable. These were the variables which were taken for my baseline characteristics. The mean age of the participants were comparable, And many of the study participants, 50% of the study participants were belonging to NYHA class 4 of the NYHA class 4 of heart failure. Then my primary outcome measure was to find out what is the change my palliative care intervention will have an effect on the patients. So here you are able to appreciate the beta estimate, which is given as 5.91. This is because of my intervention. There is a 5.91 increase in the quality of life scores between the intervention arm and the control arm over a period of 6 months, and it is found to be clinical. It is found to be statistically significant. Here I want to make a note that FACIT-PAL has a scoring as questions like 47 questions, and increase in score is found to be more good rather than decrease in symptoms. So decrease in score, and here you are and the clinical significance here 10-point score is considered to be clinical significant. But here in this I am able to appreciate only 5-point score difference. And coming to FACIT SP12, here you are able to appreciate that there is a 4-point increase score in the 4-point increase score because of my intervention, and here also it is found to be statistically significant. Next, I will be talking about this Minnesota Living with Heart Failure questionnaire. This is a cardiac specific symptom questionnaire. Here you will able to decrease in score is found. Decrease in score, it is good. It is the improvement in quality of life. Here I'm not able to appreciate a quality change in the quality of score, that is 0.15. It is actually worsening. Then if you see the patient health questionnaire, here you're able to appreciate there is a decrease. In patient health questionnaire also, decrease in score is good. And coming to the next group, who are already on follow-up care, here 88 participants were randomized into 44 each in intervention and control arm, and they were followed up over a time period. And these are the time period. And the baseline characteristics of the study participants were comparable. And most of the study participants belong to NYHA class 3. Here, as I stated earlier in my sample size calculation, 16-point difference I used for sample size calculation with FACIT-PAL. Here I'm able to appreciate there is a 15-point increase in the score, and the 10-point difference is considered to be clinically significant. So it is both statistical and clinically significant. And coming to this Minnesota Living with Heart Failure questionnaire, here I'm able to appreciate there is a decrease in the score, which is good. Because of my intervention, there is a decrease in the score, and this is found to be also statistically significant. And strength, it is a longitudinal study, RCT, and principal investigator was trained before providing the intervention. Limitation, it is a single investigator study. Multicentric trial is needed. Thank you.
So basically, you are getting palliative care, right? So probably in any medical care, there will be specific guidelines, like how you have to treat them. So in palliative care, is there a guideline? You said psychological support, but are there structured, standardized guidelines, like how to give them?
There is a structure. It depends on the patient's need. It's not like a structure because it will be adjusted according to the patient needs. Some patients will be needing, based on my assessment, some patients will be needing emotional support more rather than the physical support. Some patients will be needing emotional support more rather than the physical support. So it depends. It caters to the patient needs rather than this thing. So that's why I'm doing this multi-dimensional approach. Like everything will be covered.
So actually, in your group, you take the last time point for follow-up and
correct. This is an exploratory study. We did not have any literatures stating that we should have this fixed time point. This was an exploratory study. We wanted to do a longitudinal follow-up of the providing intervention, and that's why we took a period of 6 months, but we are not able to do that 6 months period. So that's why we put an amendment and we restricted the period of follow-up till 4 months. Because not because of mortality, because most of the study participants, there are many lost to follow. I was not able to get many of the study participants at 6 months time point, and there was a decrease in the recruitment period also. Yes, sir. No, sir. No, sir. I made sure that there is no mix-up of the study participants from the group 1 and the group 2.
Thank you, Dr. Guru. We are all our parents and grandparents not taking medication. Either they are not remembering, they are not forgetting, not caring, but basically they are not taking medications. This is a very large scale problem, very tricky problem to solve, but it's very real. And our next presenter is taking a close look at this problem of adherence. More interestingly, he's taking a look at this problem of adherence, context of cognitive impairment. So, Dr. Karthik, you may begin now.
Thank you. Am I audible? I'm good. Thank you. Good afternoon, all. My study title is Effect of Cognitive Stimulation on Cognitive Status and Medication Adherence among elders with cognitive impairment who are residing in urban Puducherry. Before and after intervention study, myself, Dr. Karthik Rajan, and my guides and co-guides are here. Coming to introduction, according to Census 2011, the elders who are aged 60 years and above accounted for 8.6% of Indian population, and it's expected to rise up to 20% by 2050. With increase in the proportion of elderly, we can expect then increase in incidence of aging-related conditions. Aging-related conditions, as I want to discuss about the cognitive impairment or visual impairment or auditory, sensory, or sleep disturbances and fall and so on. Here, I want to study about the cognitive impairment because a decline in this cognitive function affects elders by reducing their social participation and make them more dependent on others. It not only increases the burden for the elders and also increase the burden for the caregivers. Currently, for this cognitive impairment, there are no structured treatment protocol is there. Pharmacological therapies are limited. With acetylcholinesterase inhibitors can be used, but it has its own adverse events. So, and many studies found that non-pharmacological intervention in terms of cognitive stimulation therapies or cognitive rehabilitation therapies can play a vital role as an alternative to maintain or improve cognitive status. In addition, when I want to discuss about the problem statement of this, the cognitive impairment among elders in India, from different studies, we are able to find that it ranges from 8% to nearly 48%. And cognitive stimulation therapy was proven to be an effective intervention, non-pharmacological intervention over different part of the world. But in India, very few studies were conducted. And why we need to assess cognitive stimulation with the medication adherence? As I already told, as age increases, age-related condition increases, the chronic health condition in terms of hypertension, diabetes is more prevalent among elderly. And in these conditions, medication adherence is very important for the management as well as to prevent complications. When we see the medication adherence among elderly, those who are with normal cognition are found to be about 40 to 70%. This adherence goes down when they develop cognitive impairment. And studies suggest that the elderly with cognitive impairment has only 10 to 30% adherence to medications. Hence, I want to check whether this medication adherence can be improved by the cognitive stimulation therapy. And hence, my primary objective is among the elders aged 60 years and above with cognitive impairment, screen positive for cognitive impairment, residing in the urban field practice area of JIPMER, Puducherry, to determine the effect of cognitive stimulation on their cognitive status at the end of 6 weeks and 3 months. And my second objective is to check the adherence to medication for chronic conditions at the end of 3 months. So we plan to conduct a before and after intervention trial because in a community setup, conducting a randomized control trial, it has its own limitations. And so we thought of conducting a before and after intervention trial among the elderly who are residing in the urban field practice area. My study calculation means data collection period is this. And as I told, the limitation, one of the limitation conducting community trial is we can't recruit some people, we can't avoid some other because contamination can happen and many other issues can be there in the community-based setting. Hence, we recruited all elderly who are screened positive for cognitive impairment in the based on our screening tool. So the sample size was calculated to be 45 using NMaster version 2.0. The assumptions were made in this. 1.4 unit difference was found to be a statistical and clinical significance based on the studies prior, and a power of 90%. And as I already told, we need only 45 participants to prove our effect. But as we told that whoever eligible for the intervention in terms of cognitive impairment, mild and moderate, we recruited all. So 87 participants were recruited for the intervention study. So the study tool was used to assess the cognitive impairment was Montreal Cognitive Assessment Tool. Montreal Cognitive Assessment Tool was a validated structured tool with 8 domains. The score ranges from 0 to 30, and a score of more than 26 was considered to be normal cognition. Those who are scoring less than 25 were categorized to be screened positive for cognitive impairment. That can be further classified to mild, moderate, and severe. Mild can be between 18 to 25, moderate can be between 10 to 17, and less than 10 can be severe. And we excluded those who are severe because severe need further evaluation and follow-up. So we recruited only those who are with mild and moderate cognitive impairment. When it comes to medication adherence report scale, it's a once again a validated tool with a 5 questionnaire with the responses in a Likert of 1 to 5. So the score ranges from 5 to 25, and score of 20 and above is considered to be adherent to medications. And we used a semi-structured tool to collect the socio-demographic, behavioral, and clinical factors. The data entry was done using Epic 5, and data analysis was done using Stata. The change in the cognitive status, which is assessed using the MoCA scores, that is a mean score of a continuous variable, was assessed using repeated measures on ANOVA because we checked the MoCA scores during the pre-intervention, 60-week post-intervention, and 3 month at the 3rd month. And the change in the medication adherence, as I already told, it's categorized to adherent and non-adherent, and we assessed using McNemus test. This is the flow of my participants in my study. There are nearly 526 elderly who are residing in our urban field practice area. All elderly were recruited for my study, and they were screened for cognitive impairment using Montreal Cognitive Assessment Tool. Among them, nearly 24% were screened positive for cognitive impairment. And among them, as I already told, elderly with severe cognitive impairment were excluded, and elderly who are expired were also excluded from the study. After that, I recruited 87 elderly with mild and moderate cognitive impairment. And these participants were given with cognitive stimulation therapy. It's a structured therapy based on the Making a Difference tool from Spector et al. This therapy has multiple domains. It pay attention to multiple domains in terms of memory, in terms of executive function, in terms of verbal and communications. These elderly participants were trained how to perform these activities in home with the help of a caregiver. So the training was given to both elders and caregivers, and they were given with a printed booklet material to practice this cognitive stimulation exercises every day at their home with the help of a household or a caregiver. So they were expected to perform these activities 20 minutes per day, 6 days at least in a week, for 12 weeks. So it is totally 72 days we expected them to perform this. And the adherence to this cognitive interventions were made sure by the caregivers who were attended the intervention sessions. So the caregivers were given with a checklist to check whether they are performing the cognitive intervention, results. The mean improvement in the MoCA score was found to be 1.2 units based on the sample for sample size calculation. It's 1.4, and it was found to be statistically significant. For clinical significance, it was stated in prior studies like mean improvement of 1 in population level or individual level improvement of 3 score in MoCA can be considered clinical significant. Among our study participants, 30% had mean individual level 3-point improvement in the MoCA level. And when we see the recategorization of mild and moderate cognitive impairment to normal and mild cognitive impairment, we are able to find nearly 33% of participants improved. And when it comes to adherence, among the 87 study participants, 65 were found to have chronic conditions and they're taking medications. And among them, 31 were non-adherent at the start of the study. Then at the end of the study, 12 weeks remaining, nearly 33%, 32% were found to be adherent. And these are my socio-demographic factors. And this is my conclusion. So cognitive stimulation therapy was proven to be effective. We need to implement in a large scale to give a better service to the elderly. Thank you.
Any questions from the residents? Anyone?
Based on the Morris key?
No, sir. It's not Morris Key's medication. Yes, sir.
Patient self-report, how many times he has forgotten to take?
Yes, sir. It has 5 to 5. Yes, sir. Yes, sir.
We expect remember how many times they forgot when they have a problem, then will that be valid?
Yes, sir. Actually, it's a valid question. The tool is administered among all the age groups, sir. So it is validated in all the age groups, and we may consider that the elderly with cognitive impairment may not be participant, but this tool was administered by me. But they may have limitations in remembering the medication intake. Yes.
How do we say what would have happened had we not done the intervention? Is it possible that they would have improved anyway?
Yes, sir. Actually, as the repeated measures ANOVA will check only over a period of time. I have given intervention, but without a control group, we can't be very sure that the improvement is just because by chance, but it is proven statistically significant. The difference is not due to chance. But the thing is, over a time period, there happens the cognition can improve for a very minimal population, but it may degrade in a user population. For people who are categorized to be mild cognitive impairment, they are at risk for. Yes, sir.
Family becomes more aware that they should be taking the medicine.
Yes.
They ensure that it could be anything.
Yes, sir.
They just become more aware of the need to take medicine.
Yes, sir. There are so much contextual factors is there in my study. Even people, people who are young age who are there in my study. Like young old are the more common population in my study, nearly 80%.
Because I wanted to know when I wanted to know that here there's a doctor who's like somebody who's administering this cognitive stimulation. How do you assess the impact size of that? Somebody paying attention. Something like the Hawthorne effect. When you have an attentive cognitive, that might itself have improved adherence in your patients. So why have you picked this type of study before and after intervention, before and after rather than an RCT?
Yeah, as I told, the RCT in a community level is we found it like feasibility issues are there. That's why.
So how much would you say would be the impact of this Hawthorne effect
in the medication adherence scale? Yeah, it can be there because as I'm a doctor who is asking this question after a time point, the possible Hawthorne effect can be. Thank you.
Next presentation. Various sources nowadays refer India to as the diabetic or heart disease capital form. The complex problem and not tightly attributable to only like lifestyle or say environmental factors. And we are still struggling with it. Why the behind the question? Why and so is our next. So Dr. Abhinami Chandra, Department of Biochemistry, the floor please.
Good afternoon to everyone. My study title is Association between Tenascin C gene variants and the risk of acute coronary syndrome among South Indian population. It is a cross-sectional genetic association study. So introduction of my study. Cardiovascular disease is the most leading cause of mortality in India. So acute coronary syndrome, which includes unstable angina, ST segment elevation myocardial infarction, and the non-ST segment elevation myocardial infarction. So the prevalence of ischemic heart disease also increasing in urban India. Though there are a lot of mechanisms are responsible for developing atherosclerosis and ACS, and the individual's genetic risk also play an important determinant of development of ACS risk. So we decided to do the genetic study. So we have selected the tenascin C gene, which is basically an extracellular matrix glycoprotein, which is generally low in normal adult tissue, which is highly expressed in areas of wound healing and cancer development and cardiovascular disease. Various studies showed that positive association between the serum tenascin C levels, myocardium remodeling, and clinical outcomes in patients with CAD. And also inheritance of polymorphic variants may influence the expression levels of tenascin C, which account for individual variation in risk of acute coronary syndrome. So our study will provide the information regarding the interplay between the tenascin C, serum tenascin C level, serum tenascin C gene variants, and the ACS risk. So our aims and objectives. Primary objective is to analyze and compare allelic and genotypic variants of tenascin C gene with acute coronary syndrome and healthy participants, and also to analyze and compare serum tenascin C levels in patients with acute coronary syndrome and healthy participants. The secondary objective to study the association between tenascin C gene variants and serum tenascin C levels and risk scores in patients with acute coronary syndrome. So these are my inclusion and exclusion criteria for cases and controls. 300 participants were included, 150 cases, acute coronary syndrome patients, and 150 healthy controls were included in our study. DNA was extracted using reagent kit from Quagen, Germany. After that, DNA quality and quantity were checked using nanograph spectrophotometer. And then we did Tagman allele discrimination assay done using the real-time PCR. So the general characteristics of the study population, there is a significant difference between case and controls in weight, height, BMI, and BP, and also in pulse rate, blood sugar, and total CKMB, and lipid profile also altered between cases and controls. We can see the significant difference between these groups. And study parameter, serum tenascin C were analyzed using the tenascin C levels were analyzed using the ELISA, and we found that there is a significant increased serum tenascin C levels in the acute coronary syndrome patients. And then we did frequency of genotype and allele of the tenascin C gene variants for 3 SNPs. For all 3 SNPs, we have not found any significant difference. So first SNP is RS13321, and the second one is RS1234743, and third one is RS2104772. And then we did model analysis of genotype frequencies of tenascin C gene in patients with acute coronary syndrome and healthy controls. And we have not found any significant difference all 3 SNPs. And finally, we checked the influence of genotypes of tenascin C gene on serum tenascin C levels in patients with acute coronary syndrome. And we found that in SNP RS13221, that CG genotype is has high tenascin C levels. So we can see here there is significantly, which is increased CG genotype in this SNP. Likewise, in second SNP, we found that CT has increased high tenascin C levels in CT genotype. And in third SNP, we have found that the AT genotype has significantly higher tenascin C levels. So we did the linkage disequilibrium. So we have found that there is a moderate linkage disequilibrium between the second and third SNPs. And also we did a haplotype frequency analysis using HaploView. CTA haplotype frequency has significantly increased in controls compared to the cases. And discussion, the cardiovascular disease have now become the India's leading cause of mortality. Mortality due to CAD is higher in South India. So tenascin C is generally low in normal adult tissue, and high tenascin C expression has been reported in cardiovascular disease. So the relationship between tenascin C gene variants and ACS risk in the South Indian population has been demonstrated in limited studies. So we studied the association between serum tenascin C levels and tenascin C gene variants in ACS patients and healthy controls. And we conclude that high serum tenascin C is significantly increased in ACS patients. So the SNP RS13321 CG genotype and RS1234743 CT and RS2104722 AT genotypes. These genotypes were found to be associated with higher tenascin C levels in South Indian population. Thank you.
Now the session is open.
If you have thought of anything, please raise your hand. Don't think twice.
So in your study, like you have defined the study for South Indian population, right? So I was just thinking, like, why? I mean, how do you like define that South Indian population? Like, is there any rationale for like thinking that South Indian will be like genetically different from other North Indian population?
No, this study was not done in South Indian populations, sir. So this genetic study, so that's why there are limited studies available in South Indian population. So that's why we have specifically chosen that Tamilians.
That IT mentioned among South Indian
Yes.
population.
So, Dr.
Yes.
You looked at the blood levels and you looked at this polymorphism.
Yes, sir.
Are these polymorphisms in the promoter region or are they located in the exonic region?
Exon regions.
Right? Because I was a bit unsure why the blood levels should change because of this polymorphism. Why would the polymorphism lead to a change in blood levels of that protein? Are these polymorphisms located in the promoter regions so that it affects the amount of mRNA produced?
Yes, sir. Yes.
Are
That
you sure or you're not sure?
I'll confirm. I'll look into this. Ma'am?
Difference in the polymorphism of this.
I didn't get one. Cases?
You say ACS
Yes, ma'am.
related, right? And
Yes.
polymorphism is related. Cases is almost very different.
Controls.
For taking
That tenacin C, it is basically it is present in during embryogenesis, ma'am. In normal and healthy people, it level will be low. When there is any inflammation or any
Show your demographic cases and those wide variation. How are you?
Zero to 100, 2018, or is it only D not female? So she is not expressing. So 0.37, here is given as more than 8.
if strong, it is.
Equilibrium is in lot score. It is not really percentages. It looks at so it's on a scale for lots.
That should be 0.8.
Anyway, I think we can go over this later. The chair has answered.
But any any questions we can extend?
Sure.
Does anyone have any questions?
If you want to look for the association, like why not try for some Jivas like genome-wide studies? Why for this process? Jivas can be crossed. Question has been taken back. So thank you, Dr. Abhirami.
Thank you.
Since 1980s, the idea of giving oxygen to the mother before delivery, good current hypoxia method has been there. But when we deal with oxygen in this context, we have to consider it as a drug and it has to be dealt with. So our next presentation discusses the role of oxygen and Dr. Sudhi Suleiman, Department from OC. You are up for it.
Good afternoon all. I'm Dr. Shruti from the Department of Obstetrics and Gynecology, presenting my research titled Effect of Maternal Hyperoxygenation on neonatal outcomes among women in labor with pathological cardiotomogram. This was an open label randomized control trial. So there is a CTG cardiotogram is the most common reliable mode of intrapartum fetal monitoring, and the presence of pathological CTG indicates the possibility of perinatal asphyxia, and which is the third most common cause of neonatal death. So in such cases, usually we give intrauterine resuscitation techniques such as oxygen administration, IV fluid, amnio infusion, or left lateral positioning. But in our study, we are investigating the role of hyperoxygenation among women in labor with pathological CTG. We have obtained an intramural grant for conducting this research. So research aim was whether the administration of high fractional inspiration of oxygen to women in labor with pathological cardiotogram improved the neonatal outcome compared to the standard care. The primary objective was neonatal 5-minute Apgar score, and the secondary objectives were the proportion of NICU admission, umbilical cord blood gases, and the level of malondialdehyde, which is an oxidative stress marker. This was a single central RCT conducted with the superiority trial conducted with 2 parallel arms during the study period of May 2021 to October 2022 after obtaining Institute Ethical Committee clearance and CTRA registration. The study population include all the adults more than or equal to 18 years of age, singleton parturients at term with cephalic presentation in active labor with a pathological CTG. And we excluded FGR, that is fetal growth restricted babies or fetus with major anomalies, and previous cesarean section, placental abruption, cord prolapse, chorioamnionitis, multifetal gestation, and any women who's requiring an invasive or non-invasive ventilation or anatropes. The sample size was calculated based on a previous study where perinatal asphyxia was the reason for low Apgar score in 48% of the women, and we assumed a 50% reduction in low Apgar score using hyperoxygenation. Assuming a power of 80% and alpha error of 0.05, the sample size was calculated to 124, and considering an attrition of 20%, it was increased to 148. The randomization was done using block randomization with sizes of 4 and 8, and the study participants were allocated into the 2 arms in a 1:1 ratio. In the hyperoxygenation arm, women received oxygen using an NRBM mask at the rate of 10 liter per minute, whereas in the control arm, they received oxygen using a simple face mask at the rate of 6 liter per minute. So the labor was monitored by partogram and fetal heart rate by cardiotomogram, and the cardiotomogram was assessed using FIGO guidelines. And the patient who received allocated intervention for a maximum period of 90 minutes and was continued till cord clamping. Other standard care were according to the departmental protocol, and the mode of delivery was decided by the concerned obstetric team. After the delivery of the baby and the clamping of the cord, the Apgar score at 1 and 5 minutes were assessed, and the newborn was evaluated, including the NICU admission. And we obtained the paired cord blood gas analysis and level of MDA levels. Out of the 430 women who were assessed for eligibility, we included 148 women, and they were randomized into both the arms in 74 in each arms. We followed intention to treat analysis. However, there was no women who were excluded or who withdrew from the study during the study period. And statistical analysis was performed using SPSS, and the p-value less than or equal to 0.05 was considered significant. Coming to the result, the women in both the study arms were similar in the baseline characteristics like age, BMI, gestation age, hemoglobin, SpO2, and blood pressure. And they were also similar in terms of the parity and distribution of maternal comorbidities. Considering the duration of oxygenation, we observed that in the hyperoxygenation arm, women, they received longer duration of oxygen, that is 55 minutes in the hyperoxygenation arm, 43 minutes in the control arm. So in the hyperoxygenation arm or the intervention arm, they received a higher duration of oxygen as well as a higher FiO2. And this was also significant statistically with a p-value 0.003. Coming to the neonatal outcome, the primary outcome was Apgar at 5 minutes. That was similar in both the arms. And the secondary outcome, the neonatal ICU admission, which was similar in both the arms, and majority of the babies had a shorter NICU stay of less than 48 hours. Comparing the arterial and venous blood gases, the umbilical vein base deficit and the umbilical arterial lactate alone was found to be significant and higher in the hyperoxygenation arm. However, this is not of clinical relevance because it was not accompanied by neonatal acidemia. Also, the malondialdehyde levels in the cord blood, we expected a higher rate in the hyperoxygenation arm, but in contrast to this, there was a higher level of MDA levels in the control arm. In addition to this, when we compared the mode of delivery, we found that administration of hyperoxygenation has reduced the rate of cesarean section, that is 26% in the control arm, whereas 4% in the hyperoxygenation arm. So on comparing the effect of high FiO2 of 80% with standard care of intrauterine resuscitation among women in active labor with pathological cardiotochogram, the Apgar score at 5 minutes was similar. The NICU admission rate and paired cord blood gases parameters were comparable. Also, hyperoxygenation for less than 90 minutes was not associated with an increased level of oxidative stress marker. However, there was a significantly high rate of cesarean section in control arm while achieving comparable neonatal outcome. So we conclude that maternal hyperoxygenation for less than 90 minutes appears safe and practically feasible and helps ameliorate the potential risk of perinatal asphyxia. Also, it could be beneficial and substantially reduce the burden of cesarean delivery. And this could be used in a limited resource nations. Thank you.
Any questions? Residents, please. Yes, dear.
Good presentation. So, you're ready to let us clear it.
Sample size. So basically 48% was the assumed low, the main outcome was Apgar score. So low Apgar score, we obtained 48% of women having fetal distress was found to have a low Apgar score. And we obtained a 50% reduction. That is in 23%, there was a reduction with hyperoxygenation. So that 50% reduction was observed.
The outcome is the period level.
No, Apgar score. Yeah.
Whether anything other than hyperoxygenation can cause this low Apgar score.
Hyperoxygenation was used as an intrauterine resuscitation technique in addition to the other techniques like left lateral positioning, IV fluid administration, and amnio infusion in order to alleviate the factors which has caused stress and which could result in perinatal asphyxia.
One question. Why do you go for block randomization instead of internal randomization technique?
So that is considered to be superior, and that will probably give an equal distribution of equal distribution of, as far as I understand, equal distribution of all the baseline characteristics in both the arms.
Okay. A question from Nelson. I'm into this. You said there is no difference in Apgar, neonatal. How come cesarean section rates are lower in versus arm compared to the control arm?
Yes, ma'am. Actually, whenever there is a fetal distress and we administer, in one of the arms we gave normal or standard care of resuscitation. In the other arm, we gave hyperoxygenation. So whenever there is a hyperoxygenation, we observe that most of the cases from the pathological CTG, the traces were found to improve to a normal one, to a reassuring or a normal one. So in such cases, we could delay or allow the patient to continue a normal delivery and then allow for a vaginal delivery. Whereas in cases of the standard care or the control arm, when we administered the control, that is a normal oxygen, and after which it was not found to improve. The traces continued to be a pathological CTG where we had to intervene and do an emergency termination either as a cesarean section or as a instrumental delivery. But all this both we do in order to prevent a perinatal asphyxia. So we intervene earlier so that the Apgar is not affected. The baby is not affected.
And then also, I mean, I don't know because it's not a blinded study.
No.
Right? Totally not a blind study. So I still feel there might have been some blind.
But the outcome assessor was blinded. Like in the sense, the pediatrician was assessing the Apgar. So he is not, he may not know what is the intervention given.
Question is about why did one group end up having more cesareans than the
Because we intervened earlier in case of a control.
So did giving oxygen
But
make the treating obstetrician change her or his right?
Always the decision for a cesarean delivery is based on the prevailing CTG pattern and not.
See, sorry, I forgot the name.
Shruti.
Shruti, when you randomize, okay, all known and unknown variables on an average are supposed to be equal from 2.
Yes, sir.
But I was raising my hand first. Did you look at the Roxanne? That's also come. Right? Was it similar in the two groups? But my point is that if you say it is randomized and it is randomized, why should you end up with so dissimilar cesareans? Is it that the physician or obstetrician feels more comfortable and doesn't do cesarean for getting oxygen?
Both the
If that
patients
is
were
the case,
receiving.
as a country, we should take to giving mothers oxygen because
Both the patients were receiving oxygen, sir. Both the
to give mothers oxygen.
both the arms were receiving oxygen, sir. But the FiO2 was alone was different.
So that mothers don't have to undergo cesarean.
But the decision for cesarean section was based on the FHR pattern, the fetal heart rate pattern or the CTG pattern, which is a standard based on the FIGO guidelines.
So I was just thinking like in terms of unit, like each unit might have like different, some unit might like push for the last moment and they'll do vaginal delivery. Some unit might upfront take your erection. So was that factor that not just thinking may not be.
That's what I told. In a labor room, always the CTG pattern is what, or the FHR, the fetal heart rate is what decides for the decision for cesarean delivery.
Trial to see whether giving oxygen can lead to reduction in cesarean rate. That is the next. Yes.
The guideline speaks about whenever you find the CTG pathology, the time from the decision, time from the diagnosis, delivery is right?
Yes.
In the standard of care, you said you have a more cesarean section. The fact is, once you see a pathological CTG, you are going to do section. You're going to prepare and probably deliver the patient. So you are only looking at the neonatal outcome based on APGAR and mind that these are the babies which will subsequently also will have a diagnosis. And now you have a pathological. So are we justified when the standard care and the standard guideline says to be delivered in 15? So that might be the reason why you had higher cesarean section rate, which might have been the reason why they had a protected unit.
During when we identified pathological CTG, as you said, we have to intervene, but we also start the recitation protocol. Like simultaneously we start the recitation process as well, intrauterine recitation.
But it is to be delivered within the next one.
But if the CTG improves, then
CTG improvement again. Second part is you said pathological CTG. What was the pathological CTG? So that actually is the part which is again the time from the pathological CTG delivery is one of the factors which are affected.
Yes, sir.
And I don't think you are.
We haven't assessed that. We haven't assessed that.
Sorry, I'll have to end this session here. Thank you very much. Okay.
I was just wondering, isn't it the evidence for the effectiveness of cardiac fetal monitoring that itself is on shaky grounds?
I didn't get your question, sir.
The effectiveness of cardiac monitoring to improve fetal outcomes in general, as opposed to conventional monitoring, which does not use cardiac To my limited understanding, I think that itself is on shaky grounds.
Yeah, cardiotomogram has also its own limitations, and fetal scalp. It has an inter-observer variation.
Whose outcomes and all is by itself question.
I think we have a consensus. So I mean, you talk about-
Thank you so much. We wanted to assess more of a hard outcome like a neonatal APGAR, which is more easily assessed in terms of a fetal well-being, marker of fetal well-being. Thank you, everyone.
Thank you, Dr. Shruti. Sometime back. sometimes our concept is like, India is becoming the diabetic capital of the world. So I think in some years you can also see it becoming the proliferative diabetic retinopathy capital of the world. No pun intended. But the next presentation is by Dr. Gautam R, partner of ophthalmology. Floor is yours.
Good evening, everyone. I'll be discussing about my study, which is comparison of 532 nanometer multi-spot versus standard single spot green laser for pan-retinal photocoagulation in proliferative diabetic retinopathy, a randomized clinical trial. Basically, in my study, we compared two different patterns of laser. This is multi-spot laser and this is single spot laser. We compared these two patterns in my study. So in proliferative diabetic retinopathy, there is neovascularization in the retina due to the release of VEGF. Pan-retinal photocoagulation, that is laser, is the gold standard of treatment in proliferative diabetic retinopathy. So what does laser do? Basically, we apply laser burns to the ischemic retina. This causes increased oxygen delivery to remaining normal tissue. So coming to single spot laser, in single spot laser, sequential spots are applied by moving the aiming beam. This picture shows the laser parameters in single spot laser, and this picture shows a case treated with single spot laser. In multi-spot laser, a semi-automated system is used which applies individual discharges in certain pre-adjusted patterns. Coming to the comparison of single spot and multi-spot laser, the power used in single spot laser is less. However, the pulse duration is more. So the average laser energy density required will be more in case of single spot laser. Whereas in case of multi-spot laser, since the pulse duration is very less, the average laser energy density required will be low. So this will prevent collateral damages. Also, if you notice in this picture, single spot laser has less uniform spacing of burns and there are more chances of coalescence of laser burns. Whereas in case of multi-spot laser, these are avoided and there is more uniform laser burns. There are various side effects of PRP like ocular pain and macular edema. These side effects can be reduced using multi-spot lasers because they apply short pulse laser burns. There are various multi-spot laser systems available, which include Pascal, Iridex, etc. This is the Zeiss Visualis Green, which is available in our hospital. This is a relatively recent machine. So the primary aims and objectives of my study are among patients with proliferative diabetic retinopathy to compare multi-spot versus single spot laser in terms of laser parameters and functional outcomes. The secondary objective is to compare the structural outcomes between the two groups. So there have been various studies comparing multi-spot laser and single spot laser using machines like Pascal and Suprascan. Most of the studies showed that multi-spot laser had low levels of pain and it was quicker. Using Zeiss Visualis Green, there is only one study which was published in 2021 from Brazil. It showed that multi-spot laser was less painful and less time consuming. However, most of these studies used different patients for both the groups. In my patient, we used the same patient. That is, mine was a randomized control trial. In this, 30 patients diagnosed with bilateral treatment-naive proliferative diabetic retinopathy were recruited. Exclusion criteria was any complicated proliferative diabetic retinopathy like patients with diabetic macular edema, advanced diabetic eye disease, etc. So consecutive sampling was done. Right eye of each patient was randomly assigned to undergo single spot or multi-spot laser, and the other eye subsequently received the other modality. Laser procedure was done in right eye first, and single blinding was done. That is, the patient did not know which eye was being treated with which laser. Pre-laser, all patients were subjected to baseline investigations like best corrected visual acuity, anterior and posterior segment examination. Coming to the laser parameters, each patient underwent one sitting in both eyes on the same day. The number of sittings of laser per eye was 2 to 3 with a time interval of 7 days between the two sittings. At the end of each sitting, the total number of spots and laser parameters were noted. Pain score at the end of each sitting was noted using visual analog scale. Patients were followed up at 1 and 3 months and all the baseline investigations were repeated. So coming to the results, we recruited 60 eyes of 30 patients. The mean age of our patient was 51.77 years. This table summarizes the results of my study. The spot size used in both single spot and multi-spot laser was the same. The average power was more with multi-spot laser. The average pulse duration, however, was less with multi-spot laser. So the average fluence, which is the average laser energy density required, which is calculated by power into pulse duration divided by spot size, was much low with multi-spot laser. The average number of spots per sitting was higher with multi-spot laser, but the average time taken was less. This is because it was a semi-automated system. Also, the average pain was less with multi-spot laser. All these have been calculated using unpaired t-test, and the p-value was less than 0.01. These are all graphical representations of my results. As you can notice, the fluence was less. The average pain score was also less. The average time taken per sitting was less with. Coming to the functional outcomes, the difference in post-laser visual acuities between the two groups was not statistically significant. This means that both single spot and multi-spot laser have similar functional outcomes. Regarding structural outcomes, there was no significant difference in pre and post-treatment macular thickness in both the groups, which means that both single spot and multi-spot laser have similar structural outcomes. However, multi-spot laser had greater uniformity in spacing of burns, which indicates it has slightly better structural outcome. Coming to conclusion, in our randomized control trial on 60 eyes in 30 patients with proliferative diabetic retinopathy, we found that because of the shorter pulse duration in multi-spot laser, the average fluence was significantly less. This resulted in significantly less pain. Also, since multi-spot laser is a semi-automated system which applies laser spots in pre-adjusted patterns, it saves significant time. Efficacy of both single spot and multi-spot laser was similar in terms of regression of proliferative diabetic retinopathy, change in best corrected visual acuity, and macular thickness. Coming to the strengths of our study, since it was a randomized control trial, it removed the potential of bias in the allocation of subjects to the laser groups. Also, since the two eyes of the same patient were used to compare the outcomes of both the lasers, multiple confounding factors have been eliminated. Confounding factors like age, gender, control of blood sugar play a significant role in progression of diabetic retinopathy. All these were eliminated in our study. Also, individual variability in pain perception between the two laser groups was eliminated since the same individual rates the pain for the two lasers. Patients were blinded to which laser treatment they were undergoing. This eliminated bias in pain perception. Coming to the limitations of our study, retinal sensitivity could not be compared in the two groups. Comparison of retinal sensitivities between single spot and multi-spot laser holds scope for future studies. Thank you.
Which eye was treated first?
All patients' right eye was treated first, but randomization was done for right eye. Like right eye will undergo either single spot or a multi-spot. This was decided by snooze techniques. Hi, sir. Sir, actually, that's why we chose right eye for all patients. We gave right eye laser first, but the right eye was randomized, sir. Single spot and multi-spot lasers are randomized. Sir, because we took right eye and left eye as two separate case and control. Same patient evidence, but statistically we took it as case and control. This was done mainly to eliminate the confounding factors, but for analysis we took it as case and control, so we used unpaired t-test. Sir? We took it as case and control. We took inputs from the Department of Biostatistics. They told this can be done.
So as such, every patient went one intervention in the right eye, then the other intervention in the
Left eye.
So you say it's randomized or more like
Right eye was randomized to either single spot or multi-spot.
But is that like a randomization? It's more like a case control. Patient is serving as control.
Yes.
Against gold standard.
Yes. This mainly the randomization was done to avoid bias in pain perception. As sir told, the second time when a patient experiences pain, his tendency to rate the pain will be low. So mainly that was done to eliminate that bias, but it can be case controls.
Were any of the were the patients aware that they are receiving different interventions?
Yeah, informed consent was taken from all patients. We told them that both are the standard of care, and then we proceeded with the treatment.
But they were aware that they are receiving
different type of laser, but they were not aware which.
This is
not to be committed, and this is not an intervention from the just as a teaching point. You don't all these just case and the chair side. So this is a match pairs kind of study, right? It's an interventional step. But yes, we need to do randomization. You are perfectly right. At least in my limited knowledge, paired test should be used rather than an unpaired test. Use that is more sensitive. It is more likely. I have one final question. It's not a question, it's a comment. Just the statistics they have said, but it is up to you to understand why this. Everybody believes it. Because everybody escapes to that department of biochemical biostatistics without understanding why. Please get into that. Thank you.
One question.
After 5 minutes after each sitting, we will show. Average of all the 3 sittings. Each patient underwent 3 sittings of laser. We took average of 3 sittings, and that's the final value. Average. Yes, ma'am. We took bilaterally symmetrical proliferative diabetic retinopathy. We usually it will be for most of the patients it will be bilaterally symmetrical. Usually for asymmetry is possible. In that case, we have to assess for other causes of asymmetry like any retinal vein occlusion. They were excluded now.
Thank you, Dr. Gautam. So I'd like to take this opportunity to invite all of you that there are chocolates or questions from the floor. So please forget what I said about diabetes earlier and ask questions. And the next topic is something in your everyday day in and day out. Breast cancer has turned the tide of history, starting from interest to Angelina Jolie. So this is a question very close to my heart. Again, no pun intended. Dr. Sanya, Department of Radio Diagnosis, floor is all yours.
Thank you, Chairperson. Good afternoon, one and all. I am Dr. Sanya Rahman from the Department of Radio Diagnosis. The title of my study is Diagnostic Accuracy of Stereotactic and Ultrasound-Guided Conatal Biopsy for Non-Palpable Breast Lesions. Breast cancer, as we know, is a major cause of cancer mortality amongst women, and a significant number of these breast lesions detected on mammography or ultrasound are non-palpable. So tissue diagnosis is obviously difficult to perform in these non-palpable lesions, and this highlights the role of image-guided percutaneous biopsy in the workup of such lesions. Of all these suspicious non-palpable breast lesions, approximately 10 to 55% come out to be malignant, that is either DCIS or invasive, on histopathological examination. The current methods used for diagnosis of such non-palpable lesions are ultrasound-guided biopsy, stereotactic biopsy using mammography, or MRI-guided biopsy, which is currently not available in JIPMER, and it's a costly alternative. And lastly, open surgical biopsy, which has its own morbidity and it's often avoidable in many cases as well. So why image-guided biopsy? Image-guided biopsy will help us because early diagnosis of non-palpable breast lesions, which ultimately prove to be benign, in these cases, it prevents the unnecessary morbidity arising from a surgical biopsy. And early diagnosis for non-palpable lesions which come out to be malignant, particularly those cases in which there's no obvious mass but only microcalcifications, it improves the treatment outcome and reduces cancer-related morbidity in these patients. So there is a need for a reliable, cost-effective, faster and less invasive alternative to open surgical biopsy in the management of non-palpable breast lesions. The primary objective of my study was to assess the diagnostic accuracy and clinical utility of stereotactic and ultrasound-guided biopsy for non-palpable breast lesions belonging to BI-RADS categories 3, 4, and 5. And the secondary objective was to describe the radiopathological profile of such lesions. Ours was a prospective observational study conducted in the Department of Radio Diagnosis. Adult women with suspicious non-palpable breast lesions belonging to BI-RADS 3, 4, and 5 were included in the study. And those women with a bleeding disorder, abnormal coagulation profile, or any known allergies were excluded from our study. So 101 patients met with our inclusion criteria. After taking an informed consent from them, either only ultrasound or both mammography and ultrasound according to the age of the patient was done. And imaging characteristics like size, shape, margins, echoes, and vascularity of the lesion on ultrasound was recorded, as well as size, density, margins, calcifications, distortions, and asymmetry on mammography was recorded. Now, according to the BI-RADS category that we assigned to the lesions, we planned for biopsy in these patients. If these lesions were visible only on mammography, such as those lesions with no obvious mass or only microcalcifications or only an asymmetry, then a stereotactic biopsy was planned. For all the other lesions which could be seen on ultrasound, an ultrasound-guided biopsy was planned. So this is an example of the stereotactic images that we take. Here we take a pair of images at plus 15 and minus 15 degrees angle, and the lesion, if there is an obvious lesion, is located in 3 dimensions, X, Y, and Z axes. We locate in two planes, X-axis and Y-axis, and the computer using depth perception locates the lesion in 3 axes. So these are the pair images, and the arrows point towards a suspicious focus of microcalcifications. Similarly, this is another ill-defined hypoechoic lesion seen on ultrasound, which was less than 1 centimeter and it was not clinically palpable. And these are some pre and post-fire images with the needle incident that we've taken for a patient. So a total of 61 ultrasound-guided biopsies were performed and 40 stereotactic biopsies. After finishing the biopsy, the histopathology for all the lesions were collected and classified into either benign, pre-malignant, or malignant. All the benign cases were followed up, and follow-up imaging was taken at 6 months, and also a repeat biopsy if needed or indicated. And the pre-malignant and malignant cases underwent either excision or BCS or MRM according to the histopathology. And the post-operative histopathology was taken as gold standard in malignant cases, and the follow-up imaging was taken as gold standard in case of benign cases. So this is the management protocol based on the histopathology obtained. Benign cases, again, were followed up closely, and repeat imaging and biopsy was done if necessary. Pre-malignant lesions like atypical ductal hyperplasia or lobular hyperplasia underwent surgical excision, and malignant cases underwent excision, BCS, or MRM, depending on the type of pathology that was obtained. These are a few images. This is the mammography machine that we use normally, and after adding a stereotactic biopsy unit to it, it can be used for stereotactic biopsy. This is the gun that we use, an 18-gauge needle, and these are the various ultrasound needles that we used with 11 mm and 22 mm throw. So this is a representative image. This was a case of a 55-year-old lady who had a known cancer. She was already undergoing neoadjuvant chemotherapy. During the follow-up period, she developed some new calcifications. And whether to decide whether BCS can be done or MRM should be done, we needed a biopsy to confirm. And these microcalcifications were again only visible on mammography. So we did a stereotactic biopsy. And this is a stereo pair images showing the needle at the suspicious focus. We also took a mammography of the specimen to confirm that the calcification was present within the core. And this new focus of calcification ultimately on histopathology came out to be invasive breast carcinoma. So this helped the clinician decide in the management whether they could go ahead with BCS or would they have to do an MRM. And this is a second case, again, a 42-year-old lady with a small non-palpable lesion, which was visible only on ultrasound. This is an ill-defined hypoechoic lesion with angular margins, which is seen on ultrasound and presents as a high-density mass on mammogram. And ultimately, it came out to be invasive breast carcinoma on histopathology. So statistical analysis, all the categorical variables like demographic, mammographic features, sonographic features, and pathological features were expressed as frequency and percentages. And continuous variables like age, size of the lesions, number of cores obtained, and size of cores obtained were expressed as mean with standard deviation or median with range. So the secondary objective of my study was to describe the radiopathological profile of these lesions. So this is a table showing various features on imaging and its association with the final outcome, that is whether the lesions were benign or malignant. Only a few features were found to be statistically significant, namely the margins of the lesions on mammography was found to be significant with the final outcome in the sense that spiculated and indistinct margins tended to have a more malignant outcome, and circumscribed margins tended to have a benign outcome. Similarly, angular and spiculated margins on ultrasound ended up having a malignant outcome, whereas globulated margins ended up having a benign outcome. Further, diagnostic accuracy was evaluated using sensitivity, specificity, predictive values and likelihood ratios. And clinical utility was evaluated using agreement, miss, and underestimate rates. So 45 benign histopathologies, 3 pre-malignant, 52 malignant, and 1 inconclusive pathology was obtained. These are the definitions which were used for statistical analysis. True positive were those cases which were initially malignant and stayed malignant. True negative were those cases which were initially benign, but on follow-up imaging, they were looking suspicious. False positive were those cases which were initially malignant, but later turned out to be benign. And false negatives were those cases which were initially benign, but showed malignant features later. For clinical utility, we came up with other definitions like agreement rate, miss rates, and underestimate rates, which I will explain later. These are the 2x2 tables that we created for both techniques, USG guided biopsy and stereotactic biopsy. The limitation of these tables was that each particular histopathology was not given due importance. So sensitivity, specificity, and predictive values obtained for each technique were as follows. And this is a 5x5 table that we prepared, giving due importance to the particular histopathology obtained. That is, whether it was a high-risk histopathology, a DCIS, or an invasive carcinoma. And so agreement rates, miss rates, and underestimate rates were evaluated, which were comparable to other studies. The strengths of our study would be that in benign cases, it would avoid surgeries. The costs would also be lowered, and technically difficult lesions could be biopsied.
We'll take questions. Can you open the conclusion slide? Okay, so the audience has
which is better than which is better?
No, it's not a comparative study, sir. The diagnostic accuracy of each technique. So all the patients are. Yes, sir. The diagnostic accuracy of each technique, sir. We are comparing both these techniques to a surgical biopsy. Like if we did not perform. Yes, sir. We cannot say that, sir, because we have to decide, because each patient cannot undergo 2 biopsies, sir. They would be undergoing. We have.
They are looking at how good is Dr. Ramesh and how good is Dr. GK.
But we did.
They are doing 2 separate of them. That's what they decided. Okay,
yeah, that's fine. But still, the objective of the study to say that one is better than the other compared to the gold standard. So, what is that one measure that you use? Maybe diagnostic odds ratio or ROC. I think that you use to compare.
But to start with, we did not intend to compare the 2 techniques. But as such, if we independently compare the predictive values, USG guided biopsy does have better sensitivity, specificity, but it's not. But we are not comparing that to the stereotactic biopsy.
When you are not able to see something on radiology, in that situation you will see just both are like complementary and get completely different patients. So you cannot compare those two. They're like completely different. When you are able to.
So you mean to say that the guided biopsy not have done that?
Yes.
Yes, sir.
They cannot have been done.
Any other issues?
But not for benign, it's HP, right? It's only the clinical diagnosis.
Yeah, but actually in some benign cases, which had a high clinical suspicion, they ended up having an excision biopsy. So no, like these lesions were followed up at 6 months and some at 10 months, 12 months. And if they stayed the same in size, they reduced in size, there were no new suspicious features, then that was taken as a sign of the lesion having stayed benign. So that could be taken as a, yeah. No. For benign cases, there was no need for them to have undergone. We have established that we've taken follow-up imaging as a gold standard for benign cases. That we have already established that.
Positive value are based on
Yes.
You know, how come it came here? Like it hospitals are connected. Like this study was done in hospitals.
Yes.
Yeah, the prevalence cannot be shared from hospitals. So possibility was ability only or highly dependent on prevalence.
Yes. 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 Yes.
My little understanding, what I understood was all those 40 had actually undergone analysis, but can't do a biopsy.
Yes, sir.
Actually,
Yes, sir. Yes, sir. So in the yes, sir. In 40 stereotactic biopsies, out of these 20 had no obvious mass. There was only calcifications. Yes, sir.
So have actually shown that they underwent the diagnosis, and then
Yes, sir. Imaging was performed uniformly for all patients. The type of biopsy differed. Yes. Yeah. Some of them, yes, sir. Like some of them, yes. Yes, sir. Stereotactic biopsy is performed under mammographic guidance. Yes, ma'am, but sometimes there's a histopathological discordance can be there. Like invasive can be reported as DCIS because entire tissue is not assessed. But that error can be on many levels, not just on the.
How many times? What is it?
Actually, BIRADS 4A in our study, it does not correlate that well because even if many BIRADS 4A cases, which we were thinking of suspicious, came out to be benign now. So, since inter-observer variability is a limitation of BIRADS. Two to 10, 10 to 50.
Any questions or any more questions? Actually, I want to ask all the patients, all the BIRADS patients that you had, they were basically patients who had own malignancy.
Actually, BIRADS 3, usually it will not warrant a biopsy, but some lesions like an atypical fibroadenoma, which classically it's looking like benign lesion, but it has one or two suspicious features. In those cases, it is better to do the biopsy and rule a malignancy out completely. So it's decided on a case basis actually. Like, see, BIRADS 4 and 5 will definitely undergo a biopsy. But in BIRADS 3, some cases which are having some suspicious features on imaging, it is better to rule malignancy out than to wait and let it develop. Yeah, exactly. So there is no concept of screening mammography in JIPMER. So that is why the sample size of a study was low. The other studies conducted outside were multicentric, had more patients. Some of them had history of breast cancer, so it was detected incidentally on screening. And some of them presented with something like breast pain, very non-specific complaints, again, but no obvious mass.
Yeah, why did you say there's no screening mammography protocol? I think it's just that if you cannot propagating.
Ma'am, most
Concept is that it's not there. I think
most women that we end up seeing for mammography already have a report or they are BIRADS 4 or 5 with bigger lesions.
Thank you, Dr. Sandra. So, 10 excellent research papers by our excellent colleagues. So, this has been a wonderful evening of learning and exchanging ideas, and there are many people but thank you each and every one of you for Saturday evenings. Thank you so much for participating, for asking questions, and for showing up. Okay. So last but not the least, I'd like to apprise this for the next session that will be held on February 20, that is next week Friday. We have research papers by MPH and MSc students. So please do attend. And thank you for letting Bhaskar and I chair this session. Tea is being served outside. Your feet.
What yeah, group. I think chairperson. Right, so this time fun in the idea. Performance of entity. You play traditional good.
Request all of you. Please